So thank you all for your patience and attendance. This will still count toward our HIV hour. Oh, are you take off closed captioning?
It's going to be, oh yeah, I can do that.
Okay.
Okay. So let's see here, Barry. You're on camera and you
Okay.
got the audio.
All right. I'll try to stay pretty close to the middle here.
Okay, sounds good.
Okay.
Let me just get the chat open here and the participants. And you're good to go.
All right. Well, welcome. welcome to our jam meeting. I'm not Dr. Wilson, but I know him well. I knew that he's a busy fellow, so this probably not too unexpected that he might be in between flights going from to and from Tampa area. But we've spoken, we've been together on a couple of presentations, one on a national and one on a webinar sponsored by APHL, and probably within the last 12 months. So, but this is an older presentation. We're gonna have to find out what happened to the one that we just put on YouTube through our safety officer later on. But we'll go with this. So, what was the objectives again?
Oh yeah, no problem.
Okay. All right. So I know we were going to talk about ending the HIV epidemic. Still applies. It's been delayed because of COVID. It came out in 2017 with some really lofty goals to reduce new HIV infections by 2025 and 2030. Those are going to be extended out because not a lot was accomplished during the COVID years, but it's still in effect. We'll look at some recent advances in antiretroviral therapy. It may be timed.
Oh no, I'm just
okay.
trigger.
And a lot of it has to do with PrEP, and we'll talk a little bit more about the details about pre-exposure prophylaxis for HIV, and that is not for HIV infected individuals. It's for HIV seronegative individuals. So we're looking at a whole different approach of use of the antiretrovirals. And we'll get into that in a little bit of detail. And then we'll talk about some changes in the diagnostic algorithm. Some have already taken place, a few minor changes. The big changes are coming next year, or end of this year or next year. And we'll get into that a little bit. Next slide.
All right. Scrubbing.
Let me see. Let me see. We're not going to spend any time on this. We don't test for COVID, so we're not even going to worry about this slide. Let's just go ahead. I think everybody knows how COVID really impacted the clinical side of HIV. There was not a lot of clinical visits going on. So guess what? We rank number 3, and it's not a surprise. We rank number 3 in the nation, Florida does, for HIV incidence, behind DC and Georgia. So how in the world could DC and Georgia have higher HIV incidence than Florida? Anybody, you got to know the definition of incidence, so think that. That's a hint. Anybody have a guess? Well, the incidence is what? Number of cases per 100,000 population. Georgia and DC have a very small population, a significant HIV prevalence, but when you look, divided by the smaller population, the incidence is higher. The rate is higher, rate of new diagnosis. But Florida by far has many HIV cases, more so than DC and Georgia, but it's our higher population. And there it is right there, 22.7. That's still about, this was 18, and to this date, we're still in the 22, 23 cases per 100,000 population. And you can see in the COVID, actually this is right before COVID, when we were on an uptick of new HIV cases in Florida. during COVID, you see a drop. Well, that was all, a lot of that, we weren't getting the new diagnosis during those years of fewer testing. Now, unfortunately, we're going back up again. There's a couple things. Did you know that of all the new cases in the United States, 51% are in the southern states represent. So the southern states in general have a higher, contribute more than half of the new cases, about 38,000 new cases a year now. I think that's good for this one. So this is the end of HIV epidemic objectives and goals. Reaching 75% reduction in new HIV infections by 2025, and at least 90% by 2030. Very, very lofty type goal. We will not meet that. I can tell you that right now. We're not even close to it on a Florida or national scale. But it was not, it was primarily due to what we went through with COVID. But there's 4 pillars, they call it. There's an emphasis on diagnosis. You want to make testing available in about every means you can, laboratory-based, rapid testing at point of care. Treatment is a big deal. You've heard terms like test and treat or rapid ART. These are all terms related to diagnose them and enter them into therapy at the time of diagnosis, which is really tough to do. But that's what the goal is to diagnose and treat. And you would actually prescribe maybe 10 days or 30 days of meds until the rest of the confirmation results come back. If the person turns out to be that initial test was false positive, then really what you're doing is that medication that you gave them for 10 or 30 days sort of acted as a PrEP medication. So then you would discontinue that or continue it if, as a PrEP individual, if they continue to have high risk exposures. If they're positive and it's truly positive, then they would reassess based on the genotype or the viral load and maybe change the regimen that they're on or let them continue what you initially prescribed. Prevent new HIV transmissions by pre-exposure. We're going to talk about that, prophylaxis, and the syringe service programs, which that's not really impacting us here, but in South Florida it does, and in other parts of the nation definitely. And respond quickly to potential outbreaks. And this is primarily targeting where we want to look at doing next-gen sequencing or conventional sequencing and identifying doing cluster identification based on the genetic material, based on the genotypes, I'm trying to say. And so we've already got, we're doing next-gen sequencing now. How long now, Brent? About 2.5 years or 2 years that we've been. So we've got quite a bit of data that we're able to provide. And of course, the surveillance office in Tallahassee, they're wanting to collect as much as they can from all the commercial labs, hospital labs. If you have sequence data on HIV positive individuals, they would love to have it so they can look at all the different, trying to match up cluster identifications. They have like 25 or 30 different clusters they're following statewide already. Next slide, please.
All right.
I won't spend too much time on this. Part of that end of HIV epidemic is not a nationwide initiative. They're really targeting some states that have very high prevalence or metropolitan areas, which is signified by all these purplish color areas that have high prevalence areas. In Florida, if you see some of the states that are in that light blue, that whole state data is considered what they want to look at in determining the effectiveness of this initiative, because there's no single metropolitan area within that state that they can really put their assurances on. In Florida, we have about 6, 7 counties there that they're really targeting to look at our incidence rates in those states to see if we're improving or not. Next slide. So we'll just go through these pillars one by one. I think I probably already covered it. We want to use state-of-the-art testing technology, make it routine in healthcare and non-healthcare settings. The big thing now that you're going to hear about is non-clinical sample collections, specimen collections. Some people call it at-home collections, some non-clinical. Everybody's using different terms, but they're all pretty much the same thing we're looking at is, are we heading more to a time when you collect the sample in your own private home or hallway or car or whatever, and then you send the sample to a lab and for your diagnosis, then you'll be referred to a clinician probably through telemedicine. So all these are really going to go into the mix. Encourage people who are at substantial risk to get tested annually. And we see identify and implement innovation technologies like consumer control testing strategies. And that's some of that at home, either testing or at home self-collection. Next one. And I think so you have direct access testing, which is when you're in front of a clinician. And direct access testing is when you're entirely consumer controlled, minimum or no healthcare provider involvement. I had them backwards. And a lot of this is very few tests in the HIV realm are where you can do the test itself at home. We only have one FDA-approved rapid test for HIV that you can do at home. Now we're starting to get, I know there's a recent, if you're looking at the STIs, we are now starting to see we have a chlamydia GC at-home collection kit, but that's for collection. That's the next one. But still, we don't really have any at-home testing other than HIV where you're directly involved from beginning to end. Then you got your healthcare provider mediated testing. This is where you'll probably get a test sent to you, or you can get it through the internet and you'll collect it, and then there'll be instructions on where to send it and then who to contact, or the clinician would contact you to help you link to care. Next, please. Let me see. Self-testing, like I said, there's only one HIV called OraQuick Advance. You can see back in the COVID year what the Department of Health did, because not many clinics were open. You could actually ask for a rapid test. It's an oral fluid rapid test that can be done at home. And you can see by the middle of the year, the number of samples that were requested by telephone or by internet from the Department of Health really spiked. And then once the clinic started open, it dropped like a rock, because it's not the best test we have. It's just an antibody-only HIV-1 test, and or actually HIV-1/2 antibody-only, but it's oral fluid, so it's not highly sensitive or specific. And then I think we've talked enough about the mail-in self-testing. It's definitely you're going to see more and more of that in the months to come. Next one. Okay, this is the treatment. I think we already mentioned the test and treat programs. Sometimes it's called Rapid ART, standing for antiretroviral therapy. Clinicians will be really pushed now to diagnose and link them to care and start medication as soon as possible. And I think that's probably good. And it's also for re-engagement if people stop. You can go this one and then click over this. It doesn't add much to anything else. This is just a menu of the antiretrovirals that are now considered first-line therapy. You can see the IAS USA recommendations. We used to have what? I mean, in the early days, in the mid-90s, 30 to 35 different meds for HIV-infected individuals. Now we're down to like 3 regimens that are very successful. Every one of them has an integrase backbone, antiretroviral in it, so that helps really cut down the amount of resistance that you see with any 3 of these regimens. Next slide. Now, these are actually treatment. These are not the drugs they use for PrEP. Things like Descovy and Truvada are your PrEP medication. You can skip this too. This just gives another, we're not doing monotherapy, but this sort of illustrates the antiviral activity after 7 or 14 days of monotherapy. Now, of course, this is the INSTI, the integrase inhibitors, and they're in the yellow. So you can see just the addition of those to any of the other drugs. You can see a significant RNA decline just by those classes of drugs. So that's one reason those 3 regimens are very successful, because they have integrase in one of those integrase drugs component in it. Next slide. But this is not saying we encourage monotherapy. That's not the case. Pre-exposure prophylaxis. It's an estimated 1.2 million Americans could benefit from this. Again, they're seronegative individuals, and they would take PrEP. And now the studies on this also included condom use. But you'll see a lot of times when you see billboards about PrEP, do you ever see any language should be used in conjunction with condoms? No, you don't. So, I mean, that's been just, I don't know, intentionally or unintentionally left out. But to produce the data that they've seen showing PrEP has a very high rate of success in non-transmission of HIV, then it helps drive this picture. In Florida, we have right now, today, I just checked it maybe last week, about 23,000 individuals in Florida that are on PrEP. Now, these individuals, they can either, I'm probably stealing from a slide coming up, but I'll do it anyway. You can either take an oral medication once a day. You can do if you know when you're going to have your risky exposure, you plan your risky exposure, in other words, you can take a what they call a 2-1-1 dosage of your oral medication. And that's, you take 2 pills 24 hours before the exposure, 1 pill the day of the exposure, and 1 pill 24 hours after that. And it's sort of like, I don't have to take it every day. If I know when I'm going to have unprotected anal intercourse, then I plan it and just take the pills when I need it. And it's very successful. If you're not going to do that, if you don't know if you're a spontaneous person, you better take it every day. You know? And then there's this, they call it the long-acting injectables. If you don't want to be bothered by a pill a day or the 2-1-1 regimen, you take actually 2 injections of 2 different drugs every 2 months, and that's it. And you know, you'll have to do that 6 times a year. There is some new drugs coming out where they're projecting now that you only have to take those injections twice a year. So this is one of the questions I had set for Dr. Wilson, was because he sees this, he sees the success or not of people adhering to these just ever so often type of interventions. And that's something that we'll have to see in the future as this becomes more common. There's some people at CDC actually predict, we have HIV diagnostic testing at the state lab, at all the labs here. We have your routine, I call it serostatus determinations. They're predicting that most of the testing in the future will be PrEP oriented, not diagnostic. In other words, everybody at risk will be on PrEP. That's sort of hard to believe, and you'll have very few times where somebody comes in and needs a serostatus determination if they're infected, and because they weren't on PrEP. Most people feel like these people that know if the message is out there that the PrEP is available, and they know their risk exposures and whether they have it or not, and they choose to be on PrEP, then you'll just do the monitoring. And we can get into that in a minute of what goes into monitoring somebody when they're on PrEP. It's not an easy clinical appointments and things you have to do to qualify for it or to stay in it. And I won't go into the syringe program. We're not really doing too much of that. Next slide.
It's a big one.
Yeah, this is probably, I've already talked about it. Truvada and Descovy, you hear them advertised on TV all the time, right? Those are the PrEP medications. And there's some of the evidence I just let on that there was condom use also recommended, but somehow gets lost in the translation. Long-acting and PrEP injectables. It's not always when to start PrEP, it's when to stop PrEP. And there's a couple of times you should really consider getting off that pill a day is when you become HIV positive. You don't want that just one pill. You want to transfer to a traditional antiretroviral therapy. Abnormal renal results. This has some issues about some of your renal conditions, and that's part of the monitoring is you have to have your liver enzymes tested about quarterly at least. Non-adherence. If the person is not going to take the meds either every 2 months injectable or a pill a day or the 2-1-1, then they might as well not take them at all. And no longer at risk. If somebody has a long-term partner, they probably do not have to take, the PrEP. Next slide. I think we probably could drop. This was probably to a group that had some epi people in it. We'll just skip these epi slides here. Let's see.
We still like epi people.
We still like epi
Yeah.
people, but I thought we wanted more clinical. But
I understand.
yeah, this is the last pillar where we're talking about surveillance activities. And this is typically how you would do the sequencing, how it benefits the clinical aspect in case you have to change retrovirals, and then how it benefits surveillance, looking at in our state, how many clusters are identified to get, as unique, and following up to see if they're increasing or decreasing. Next slide. A little bit about testing now. Who remembers first generation test, second generation test, third generation? All that pretty much is gone because it was abused by the manufacturers. They started saying, hey, this test differentiates this from that. So now it's considered a fifth generation test where it really did not improve the sensitivity and specificity over a fourth generation. It just had a different piece to the construction of the assay or the automation. So what we did, we're encouraging to get away from the generation language. And everything can be broken down into 3 categories. You have your antibody detection only assays, you have your antigen antibody detection assays, and you have your nucleic acid assay. A lot easier. And it makes your life easier dealing with the vendors sometimes. Next step. Okay, y'all seen this. You lived it for what? Ever since 2014. This is the diagnostic algorithm since then, and it's about to change pretty significantly later this year or early next year. And I think I have a slide on that. All right, next. Does anybody, is that new to anybody? Would you let everybody understand? What you may not, go back one quick,
Of course.
is one of the biggest advantages of this, you can differentiate established infections from acute infections with this. You cannot do that with the old algorithm. If your antigen antibody test is positive and your HIV-1 is positive, this is the Genius. We do have a competitor on the market, but we all know this test as the Genius. HIV-1 is positive, you stop right there. That's an established infection. If it's HIV-2, you got an HIV-2 case, theoretically, you have to maybe do some RNA testing to confirm. HIV-1 positive, HIV-2 positive, dual infection, right? Probably not. It's probably an HIV, very strong HIV-1 with some antibody cross-reactivity in the envelope protein to the HIV-2. So if you diluted that sample, you would end up with an HIV-1 positive. Or it could be HIV negative or indeterminate. If it's the last, then you do an RNA test as a tiebreaker. If it's positive, RNA positive, you have an acute infection. The idea there is an acute infection is defined as the absence of antibodies to HIV-1. That's the thing that triggers it. So the top is antigen antibody. Most of these you cannot differentiate the antigen from the antibody reactivity. So you just say the top is the antigen reaction. And if you're negative for HIV or even indeterminate on the antibody only test, which is the differentiation test, and then RNA positive, you got that pos reaction. And that's what we consider an algorithm defined acute case. And if it's negative RNA, more than likely that screening test was false positive. Now we can go. This is just some of the assays. We can skip over this. This is the antigen antibody non-differentiating assays. Okay. And then we have differentiating assays. Some of you may have one of these assays like the Bioplex 2200. There's three different, there is a third one that's not on this one, that's since 2020. But you can have 5 different results off the Bioplex 2200. It's a screening test. Just because it differentiates the reaction from antibodies to antigen doesn't make it a confirmatory test. It's still a screening test. And the Alere Determine, now Abbott Determine rapid test that some of you probably have used or seen, it also can differentiate HIV-1 and 2 antibodies, but not among themselves, from the antigen. So it is an antigen antibody differentiation. And likewise, it's not a confirmatory test. So you may have people say, well, if it can differentiate, it's a confirmation test. No, it still has to be, what did the FDA approve it as? And in this case, these are all approved as screening tests. Next, I think I just have some examples of it. So this is the one that most of us know, the supplemental, the Genius test. There is an additional one. I didn't realize it was after 2020, but it's put out by Avioc. It's called Bio1 Profile. It's a 96-well confirmatory test. And for those of us that still like to do multi-channel pipetting, they designed it just for you. And next. So and these are the results of it. When you see these that are circled, the assay interpretations, we end up having to do RNA, HIV-1 RNA, and if that's negative, we do HIV-2 RNA, or we send it off for it. Next slide. RNA testing, besides Cepheids, where'd she go? Oh, she left, yeah. This could actually be, it's not really a laboratory-based test, and you need to grab your package insert and read it. It is got some strange limitations, but I think a lot of this will change. We're anxious to see when that was for HCV, I should say, when this is going to bleed over to HIV. Usually what happens in HCV, by the next year will be happening with HIV. So when you see rapid tests come out for HCV, you'll see the same thing for HIV a year later. I predict the same for the Cepheid point of care HCV rapid test. That's an RNA test. Next year, we'll probably be seeing it introduced as an HIV, probably just for qualitative use only. I doubt if it will have the capability of getting to the lower detection limits as a laboratory-based RNA test can. That's, we say we like to see below detectable limits for HIV to be like less than 30 copies. That would be a hard thing for a rapid test to do, but we'll see how it works out. But we're familiar with the Aptima HIV-1 RNA. We also have now Abbott has a dual claim for diagnostic and clinical management, just like the Aptima is. And we have a Roche HIV-1, HIV-2 qualitative RNA test. It can differentiate between HIV-1 and HIV-2 RNA. It doesn't have a quantitative claim, though. So that's sort of strange. I said you should have waited another 6 months and got a quantitative as well. But where the market for a test like that? It's the first HIV-2 RNA test on the market, the only one right now that is FDA approved. It can be useful for PrEP when we talk about the PrEP algorithm in a second. I think we can go over next one. So some of these have already come about. Yeah, well, all of these are, yeah, but they're pretty much in routine use now. They were new back then, but these are pretty much in routine use. Next slide. I'll give you some update now on the changes, upcoming changes for the algorithm. This is the algorithm, and for those sites that are using a differentiating antigen antibody screening test, I gave the Bioplex results. And you end up, or this could be the Abbott Determine also. If you get HIV-1 antigen P24 reactivity, you can click on it one time. It's going to give you a shortcut.
Oh, like here?
Yeah, right there. There's no need to go down to antibody testing, differentiation antibody. Go right on down to RNA because you got an antigen reactivity. If the RNA test is negative, you may want to go back and do antibody testing. But this is what I call a minor change. It just makes sense to do it. Why go from an antigen positive screen to antibody testing? You go right to RNA. Okay, next. This is a major change that is not approved yet, but you're getting sort of an advanced look at it. You screen with antigen antibody assay. And why? Why would you do that with RNAs available now? RNA testing is so commonplace now. It's the cost. If you're doing a large number of individuals, it's still much less expensive than doing an RNA test. Even if you're doing a lot of RNA testing like we are, where it's still maybe $30 a test, that antigen antibody test is probably $3 a test. So it's going to be a long time before you see an initial RNA for first or RNA only test. That's what they want, is an RNA one test and done type of algorithm. But it will be a while before that price point gets there. But now what happened here is expect to see this RNA and Genius flip-flop. Any reasons why you would want to do that? Why you would flip-flop your antibody testing and your RNA testing to the number 2 spot? It goes back to it goes back to what Dr. Wilson was here for. That's your hint. He's the one that would want this really, really bad, because he's going to make treatment decisions quickly. He is for clinicians primarily that either want to or are being sort of forced to do same-day diagnosis, linkage to care, and get them on antiretrovirals. So you really want your top best tests so that you can get that decision quick, and then get them into care. Now, if the RNA test is negative, a lot of people say, he's negative. I don't have to start treatment. I don't care if he's got antibodies or not. I mean, but from the laboratory thing, I'm curious when the first test, antigen antibody is positive, and the RNA test, when we end up doing this, if it's negative, we should all think about why. Why would you have discordance? And here's 4 possible reasons. The first test was a false positive. How would you prove that when the RNA test is negative? You got to do antibody testing to prove it. So it brings in the Genius again. What if it's an HIV-2 case? You would miss every one of those. We don't have many, but you would miss every one of them. And you would need to see it right here in the Genius, the second result, if it's an HIV-2. Antiretroviral use that is non-disclosed to anybody. Sometimes we see cases where individuals are taking their partner's meds. They're infected, they don't want, they just rather take their partner's meds than get their own. If they feel like if they disclose that, they get in trouble, they may not, and that may account for their antibody positive with the first test, the RNA is being suppressed with the meds, and you need the third test to prove that as well. You need that antibody positive right here, the first one. Elite controllers, there are very few, I don't know, they say 3 to 5% of the old Western blot positives are what we call elite controllers. They'll be Western blot positive every time, but they never have a viral load, and they're drug naive. So how can that be? It's the body is keeping the virus in check without the medications. So that could be another reason why you have antigen antibody reactive, because you still have antibodies, but you don't have RNA. So the RNA would be negative. So the only way to be able to separate an elite controller out is to prove that they have antibody down here as well. And they're drug naive, so they can't be the third one, they aren't used. So there's several reasons why you want to maybe complete the algorithm, but just have it inverted. Next slide. These are just some of the benefits. I think I went over them all. Gets people into care right away, reduces that wait time. Let me see. It's a problem. It supports antigen antibody RNA quantitation algorithms for acute infections. Next slide. And there's some barriers too. You can skip that. This is just some of the data supporting it. And there's some of the barriers. I think it was, you're not able to discriminate an antigen defined versus acute infection versus established unless you do the entire algorithm. But like I said, for treatment purposes, you're going to see a lot of people just stop after that RNA as the second test. So that's not approved yet. It probably will come out that way by the end of this year. through CDC. They'll have some new recommendations coming out. I think that might be close to the end. What else we got? Oh, this is predict. Let's see, what's on the horizon. Let me see. Panthers are already there. M's there. Cephia Gene Expert, but it's not on the Gene Expert. It's on the Expert Express. Is that what it's called? Cepheid Express, which is a different platform than the Gene Expert. And then there's others outside the U.S. That are in the pipeline to come to be rapid HIVs. You may see another rapid HCV RNA before you see an HIV, but I would say by next year we'll be seeing some of those. Next slide. Again, this is the continuum of care. This, I think it's up a little bit now because we're sort of high incidence rate. We're not seeing as much improvement, but you look at what percentage of your diagnosed population are linked to care. But there's, with the new policies now of diagnosing and linking to care, it should be higher than that. Retained in care means that they've had scripts for probably at least 2 3-month periods. And then viral suppression is less than 200 copies per ml unless they're going to change it. And I think this is probably it.
That's it, pretty much.
Yeah, there's if you ever want, this is currently being, if you ever want to know a lot about how to interpret all these results from the algorithm, APHL has put out a neat little fact sheet. Actually, it's several pages. I can send that to you. Just drop me an email. And I think the other one is specific for Bioplex. So any questions? I don't know what
That was the next, that's the next one for
that's the
tonight.
next one, huh? Any questions? I didn't get a whole lot like clinical like he would have done. Yeah.
Expensive is that injection for patients? Does insurance cover that or?
I think they do. Yeah, I think it is now. Yeah. And I don't know if it's, I know there's one, I don't think it's approved yet, but there's a 6-month where you could probably find a webinar online that talks about the next generation of these injectable, long-acting injectables. And instead of doing it every 2 months, you'll do it every 6 months. But there's some issues about that as well, as people go too long being, not being monitored. I didn't get into that now, but this is something that we're looking at the state lab, is that we're setting up a PrEP monitoring algorithm where that if an individual is on PrEP every 3 months, if they're on the oral medication, they are monitored on how they're doing. They have to be seronegative to continue. And that involves RNA testing, antigen antibody testing, nothing else in the way. You don't have to do antibody testing. Those two only. And then you're encouraged to do STI testing, liver enzyme testing, and maybe something I'm forgetting. So that's what they do every 3 months while they're on therapy. So you can see that's not an easy task itself. And the same way with injectables, they get their injections every 2 months, but when they do that, they're also monitored for those same analytes, same tests. So it's not that easy, but it's better than starting treatment after you become positive. So it's much better than that.
So is there, if somebody was sexually assaulted and they know that they were going to possibly be exposed, would PrEP be applicable to a sexual assault victim or?
Yeah, it's exactly right. It's the opposite. You almost said it. It's PEP, post-exposure prophylaxis. And it's supposed to be administered within 72 hours of the risk behavior, and assuming like this, we're talking about like rape, but it could be occupational exposures. That would also be, you would do a PEP for that. You would start within 72 hours and then discontinue once you get the results that, either results of the individual, I don't know how you would do that unless they made an arrest, I guess, or in the case of occupational exposure, you can, get the sample to be tested. If that's not possible, then of course the employee is, the first test you want is the RNA test. You don't want to spend time on the antigen antibody or the antibody test. You go directly to RNA about 8 or 9 days after the exposure. Good question. I'm trying to think of what else he would have talked about that I could have covered, but
Mary,
I've heard
Mary, can you hear me? It's Mary Claire.
Yeah, go ahead.
yeah.
Could you talk about, I don't know what you know about it, but I know that the other speaker would have, but the efforts in terms of focus and what that whole effort is with testing people that come into the ER.
Yeah, that's something I would, that I thought he was going to definitely cover. That's about the extent of my knowledge that it was focus. Do you know what the acronym stands for?
Oh, now you're putting me on the spot.
I don't either. I just know it's centered on emergency departments, and I would assume that they probably would be looking at, they can do a rapid test and link them to care, and then actually prescribe meds for them. Now, whether they do it 10 or 30 days, you got some info on it?
HIV on the front lines of communities in the United States.
Yeah.
Yeah, so it's anonymous testing of patients that come into the ER. Or is it anonymous? Actually, I don't know.
I
Let me
don't,
not
well,
say
I'm
that.
pretty sure they link them to care. and
Yeah,
start
so it's
from
more
there.
like when somebody comes into the ER, offering them an HIV test, no matter what they are presenting to the ER with.
Right.
And it started in, a handful of ERs throughout the state, but the governor is keen to expand this effort. So we'll see more testing going on with focus.
True. Yeah. Good point. So we missed that point from him.
As far as testing, the guidelines come out, say at the end of the year or next year.
Yeah.
What is the expectation, like what was seen with our current algorithm when it came out? What is the expectation of laboratories transitioning to that? Or will it be certain types of,
Yeah.
hospital types that the focus will be for changing it? What is your perception of how that will go?
Well, I think it may come down to cost. I think if CDC had I don't know, I'm just pulling a number out of thin air. If they had a RNA test that can be performed maybe less than $20, or maybe better be less than that, probably less than $10, which is the cost of a lot of rapid diagnostic tests. If you can get the price line of an RNA test down to the same as what we're paying for any of the 9 different FDA approved rapid tests for diagnostic, then they would really push to have that in the number 2 position. So that would be the issue. Why it hasn't happened yet is because you have to, I guess, saturate the market with a need for RNA testing to make the cost drive down.
So would the update drive manufacturers to reduce their pricing, or no, you think just increase in testing?
Yeah, I think
Drive
it will help drive the cost down because you'll be doing more of them. Now, but what the manufacturers really want though is one and done. They want RNA tests first. That's where they make more money than being in the number 2 or the number 3 position. The algorithm that we see now, the three test algorithm now, is a diagnostic algorithm. It was designed for that back in 2012. You know, actually it was way in development before then. Now the emphasis is on clinical management, you know, get them into care. So that's the reason that we're looking at bringing RNA test up first, because it's very sensitive. You're going to pick up those acute cases. They may not be able, we won't be able to define them as acute cases unless we do the third test, an antibody test, but that's regardless. If they have a 7 million RNA copies as the second test, you can pretty much hang your hat on them that they're an acute case to have that level of RNA. But it's immaterial. You're going to start them on therapy right then. So we're really not having the importance of acute versus established. It's probably going to go away when RNA becomes the second test, because everybody will be linked to care based whether they have 1,500 copies or 7 million copies. They're going to be linked to care if they are not already, or they're like re-engaging. So it's going to be simplified, I think.
Since doctors don't really combine their own drug classes anymore, do you think there's still a clinical role for sequencing, or do you think that the drug-resistant mutation sequencing, all that stuff, has moved more into the surveillance realm?
I think it's moving. I mean, we've sort of seen that ourselves, right? I mean, we are seeing more integrase mutations than I expected. I mean, we both, I thought, you know, I remember one time they said when the integrases came out, they were foolproof. You know, we don't really have to do sequencing. We just give them a regimen that's got integrase in there. They're good to go. But I think we've seen quite a few, and we're seeing more. Yeah. Yeah. But the surveillance aspect, it's going to be is part of the pillars, you know, so they're going to put some emphasis on it for sure. They want to identify clusters that maybe they haven't seen before. But that's a costly surveillance tool, as we know. Yeah. Anybody else? Okay, well, thank you.
Thank you, Barry.